Hi everyone. Got a little extra bonus footage here for you tonight. I'm currently in my illustrious home office, which actually happens to be the kitchen here at Casa de Walton. This is what I call my second work day. After dinner, kids are out, sit down, tuck into a little bit of work. Anyway, for those who have ever taken any of the courses, especially the Assess, Predict, Treat or the Comprehensive Pain Assessment course, or for those who have watched any of my series of YouTube videos on comprehensive pain assessment, you'll have heard me talk about the concept of triangulation and of the idea that I believe that three independent signs that all point in the same direction should be enough for you to decide whether or not you've got a particular problem in that area. On the other hand, if you don't get at least three, it's a little bit harder to say that maybe there's a problem as far as a patient's cognitions or their nociceptive processing or a neuropathic pain condition or whatever the case may be. So anyway, I believe that for the most part, from a clinical utility standpoint, three individual tests that all point in the same direction or all have similar results are enough to usually make that call. I wanted to describe that mathematically. I have said from time to time I can prove this mathematically if you want. You know, a bit of a smartass, I suppose, but I'm actually going to take the time to do that today. So I've got a screen capture set up here on my computer. Hopefully this is going to work. I've actually got two different screens going here, and I am not a technical genius, so here's hoping this works. I've got this little microphone here. I'm not even sure if I need it, but what the hey, here it is. I borrowed the term triangulation really from I guess either the military that probably initially described it, but it's used a lot more now in terms of cell phone location. So as an example, you know, the good folks at Google, I'm sure, know exactly where I am right now, fairly closely. And the reason for that is, let's imagine there's a cell tower. Actually, there's one just about 300 yards from my house. And let's imagine that cell tower can see my phone, or my phone can see the cell tower. If this cell tower has a radius, if you will, of sort of detectability, let's call it 10 kilometers. Let's use metric, why don't we? Then, if my phone can only see that cell tower, all that Google knows is that I'm somewhere within 10 kilometers of that tower, but I could be anywhere within that 10 kilometer radius. Now let's imagine that my phone can also see a second cell tower. So let's imagine there's another one and it's 15 kilometers in that direction. Now, if that's the case, there's a little bit of overlap between these two towers, but Google are starting to zero in a little bit more on where I most likely am. Now let's imagine, though, that there's a third tower, or maybe there's a Wi-Fi router. We know that Google's quite good at using our Wi-Fi routers, knowing which ones we're connected to sort of triangulate our location. And so let's imagine this is a slightly smaller circle, but let's say my phone can also see that point. Well, now we've got 3 points of sort of intersection. There's really only a very small sort of area in which I can be located. And so as a result, even without GPS tracking, Google is usually fairly good at knowing about where I am. So I want to use that concept to apply it to maybe trying to determine if a patient has a particular condition, or what we use it for in the comprehensive pain assessment approach is to try and figure out if there's dysfunction in a particular system. So some of you will also have seen the radar plot that I use and that Jim and I use when teaching those courses. If not, you can go and check out one of my earlier YouTube videos. We've actually got a new revised radar plot that we're using now, and we're just writing a paper on it. But you can find it online. I'm fairly certain there's one on our website. So the question being, is there dysfunction in these different systems that might help explain this patient's pain experience? So let's imagine that we're looking at a neuropathic pain problem. We think we've got a patient in front of us, they may have a problem with neuropathic pain. And I'm just going to use that as an example. There are, in fact, more defined criteria now for diagnosing neuropathic pain, thanks to the International Association for the Study of Pain. But let's just imagine we're going to use a few different clinical tests. Patient is in front of us. We think they may have a neuropathic pain problem, but we think there may possibly be other things going on as well. So let's just take, I'm going to use a very conservative approach to describing this concept of triangulation here. So let's imagine that you're 25% confident that the patient has a neuropathic pain problem. So let's call that your pretest probability, which is 25%. Let's also imagine that you've got 3 clinical tests you can apply, all of which, when positive, sort of move you closer towards a diagnosis of a neuropathic pain problem. I've chosen 3 tests of moderate discriminative validity here. So you can see the first one, sensitivity and specificity are both 0.8, which is fine. We usually don't get too excited by it, but it's not bad for a single clinical test. And we can calculate a positive likelihood ratio from that, which is just sensitivity over 1 minus specificity, of 4.00. Then let's imagine we've got a second clinical test. This one's more modest. It's sensitivity and specificity are both 0.75. Probably somewhat realistic for an individual clinical test that we might use. And again, we can calculate a positive likelihood ratio of 3. And then finally, we've got a third clinical test. This one's somewhat equivocal. We're not super excited by it. Sensitivity of 0.66, specificity of 0.67, which is basically 1 and 3 on both of those. Or sorry, 2 of 3, I should say, on both of those. And there the positive likelihood ratio is 2. So if we go back to our pretest probability then, I said we were 25% confident that the patient in front of us has a neuropathic pain problem. We can put that into odds. We can talk about our pretest odds now. So if we're 25% confident, that means for every 100 people that come into our clinic that look like this person, 25 of them would have that condition, but 75 of them would not. So of the 100 people, if we're 25% confident, then 25 would, 75 wouldn't. Now, because we like to work in smaller numbers, those numbers are a little bit unruly. Let's shrink those down to 1 to 3 odds. Okay, we'll divide them both by 25. So in this case, for every 4 people that look like this patient in front of me, 1 has neuropathic pain problem and 3 don't. Okay, that's our pretest probability. In other words, they may have other things that are not necessarily neuropathic pain. Central nociplastic changes or something like that, perhaps. Now, let's say we go ahead and we apply our first clinical test. And if you remember, I said the first one had the best sensitivity and specificity, so the best diagnostic validity, and it was its positive likelihood ratio was 4. So we apply that test, we get a positive result. What we do then is we take and we multiply our pretest odds by 4 now, because the positive likelihood ratio is 4. And so now what we've got is 4 to 3 odds. The way we interpret this then is we could say that for every 7 people who looked like that person initially and scored positive on that clinical test, now 4 of them have the condition, 3 of them don't. So now my odds are 4 to 3, and I can calculate now a post-test probability by dividing 4 by 7, right? So 4 out of every 7 people here, which is now 57.1% as a post-test probability. So now I'm 57% confident that this patient in fact has a neuropathic pain problem. But 57% isn't great. Might as well flip a coin. They do or they don't. Fortunately, we've got 2 other clinical tests that we're going to use. Now let's say we go and apply our second clinical test. This one was a bit more moderate in its discriminative validity. It had a positive likelihood ratio of 3. If again it's positive, now we again multiply our pretest probability or pretest odds by our positive likelihood ratio, and now we end up with a 12 to 3 odds. Okay. In that case, we once again say, okay, now for every 15 people we have, 12 of them have a neuropathic pain problem. So every 15 people that look like this patient, 12 in fact have a neuropathic pain problem. Once again, we can calculate our pretest probability, and in this case now it's 80%. Not bad. 80% positive, I'm feeling pretty good about that. However, I might recognize that if indeed I diagnose this patient as having neuropathic pain problem, the treatments might have a bit of side effects, right? So we might get into some pharmaceutical treatment, and we know that the pharmaceuticals for neuropathic pain problems potentially have some side effects. We don't want to jump right into that. until we're fairly confident that that condition exists. So now let's go to our third clinical test. Now, if you recall, our third test really was pretty mediocre as far as discriminative validity. Its positive likelihood ratio was only 2. But once again now, I can take my pretest odds after my last test, which says of the people who look like that initial patient that came into my clinic and who have both of those last 2 tests positive, I'm currently 80% confident that that person has a neuropathic pain problem. I now apply my third test. Its positive likelihood ratio was 2. I again do the math. Now my post-test odds, assuming a positive test, are 24 to 3. In other words, now, of every 27 people who I see in my clinic who look like this patient and have these 3 tests positive, 89% of them, 88.9% or 89%, do have a neuropathic pain problem. At 89%, I'm fairly confident. I'm okay to make that call. There are times when you're going to want to be more certain, or there are also times where you might make the call when you're a bit less certain. It really depends on sort of the nature of the intervention and kind of what the potential trade-offs are for being right or for being wrong. False positives and false negatives and all that sort of thing. But what I've done here is I've said, we started off with only a 25% confidence that the condition exists, which is not great. I think most clinicians are probably a bit better than that at recognizing patterns and estimating whether a condition exists. We've applied 3 fairly modest clinical tests, positive likelihood ratios of 4, 3, and 2. These aren't great, but they're probably somewhat realistic for some of the tests that we've got. And as a result of that, we're now 89% confident that that condition exists. That, in my mind, is the concept of triangulation. Now, it may be that a positive test for neuropathic pain is also a negative test for another, let's say, a nociceptive pain condition. Or vice versa, that a positive test for a nociceptive condition might be sort of negative for neuropathic pain. And so sometimes negative can still lead us towards a likelihood that a condition exists. It gets a little bit more complex. Let's not make it too confusing. We'll leave it at this for the time being. But hopefully this makes sense to you. So what I've just shown you here is that, again, with 3 tests, so this is where my triangulation comes from. This one says yes, this one says yes, and this one says yes. Even if they had fairly modest discriminative validity, the probability that my condition exists went from 25% to about 89%. Now, some of you may say, but Dave, you're ignoring the prior odds fallacy. If you're saying that, first of all, good for you, smarty pants. You're probably far too smart for this video. Second of all, you're probably right. So the prior odds fallacy has to do with the likelihood or the diagnostic accuracy of a test, assuming we've already conducted other tests, which normally we don't do in a research perspective. Normally when we do research, we kind of take everyone as though we're totally blind to whether or not they have the condition and then apply our clinical test, and so we get different likelihood ratios. Long story, but at the end of the day, what that probably results in here is I may be inflating the estimates just a little bit. If we're worried about a 2 or 3% inflation in this case, I don't think we are. But anyway, that's one of those caveat things that academics like to talk about. So there you have it. I occasionally will say that, hey, if anyone wants, I can try and mathematically prove the idea of triangulation, and hopefully you get a sense of sort of where I'm coming from. Obviously, if you started with a higher pretest probability at the outset, or if you had tests that were more accurate than the 3 hypothetical ones I've described here, you'd end up with even better odds. But anyway, hopefully that explains what I'm talking about, and good night.